Thank you, Vasan. Thanks for the opportunity to speak here. It's quite a unique opportunity for someone from a company to come and give a lecture on fundamentals of light transport. My name is David Kucha, and I work at Modulated Imaging. Like Vasan said, we founded this company in order to push forward the applications and the delivery of various embodiments of spatial frequency domain imaging, which I'll focus mainly on today. The talk is titled Spatially Resolved and Spatial Frequency Domain Methods and Their Biomedical Application. What I'll try to do, since I'm very biased towards SFDI, I'd like to tell a little bit more of the story of how we developed that and the biomedical applications, and also the validation of instrumentation. I think it's an interesting story for me, and it's also tied to computation at various stages. Just because something works in a simulation doesn't necessarily mean it will work in real life. So I'm also the chief architect of the Virtual Photonics Technology Initiative. Admittedly, I don't spend a lot of time with the group these days, and I miss our old days, but I'm grateful to be associated with the project, and a lot of the tools that you guys use in the GUI workshops are things that I helped work on and deliver. So I hope those are working for you. I borrowed this slide from Sylvain Joux, who delivered this talk last year, and I love it. So the clinical problem that overall that we're trying to address, that I'm working on addressing, is the fact that in 1969, surgery looked like this, medicine more generally looked like this, and in 2014, it looks exactly the same in many, many ways, except for maybe RGB contrast. There are a lot of places in medicine where looking at it and making a gut decision is still the standard of care. That can work in many instances. Highly trained people can make good judgments. Cancer diagnostics, for example, and histology is one of those. Other places, there's disparity of care. There's patients like people in nursing homes that have wounds that won't heal, and nurses that are there get 6 weeks of total training, and we're unable to deliver accurate ways of diagnosing and treating tissues to those kinds of populations. There's also disparities in terms of skin types, so being able to assess something visually, with a dark skin versus light skin, you can have much different outcomes. And this talks to that. So the standard of care is often clinical impression, and Marianne Sinet, a burn collaborator of ours a few years ago, said, physicians still lack an objective means to determine tissue health at a specific location. Here's an example. So we created a simulation of a wound that would happen during surgery. So venous congestion can happen when a breast cancer patient has a tumor removed and then their breast is reconstructed. The surgeon rewires up blood vessels and wants to know at the end of surgery, is everything okay? And this is what you would see with your eye. You can see that this is the occluded side and the control. And this is what we see with instrumentation we're building. So here's a pseudo-color map where yellow means there's lots of oxygen. This is a quantitative scale. They can compare these numbers in space, in time, for the same patient, between patients accurately. And you can see very obviously that this flap down here is completely lacking of oxygen, and if left like this, it will die. So this is the general problem. To give you a little bit more context of things that I think about every day, we're looking at diagnostic tools for assessing wound perfusion and predicting healing potential. So the standard of care for looking at perfusion of tissue is the doctor or nurse poking the tissue, looking for capillary refill. Basically, it goes white and it comes back red. If it stays red, that means there's infection. If it's white, that means there's no blood flow. But this is all very qualitative. And so I'm interested in developing quantitative tools that allow you to do that more accurately for a variety of things. We also had a nurse tell us once that African American patients don't have capillary refill. And I thought that was the most ridiculous thing I'd ever heard. But it tells you kind of how different people project the same problem in different ways. When she said that, I think she meant that if it's the visual understanding of the blood coming back that she can't see. And so that's a big disparity. If you can't see that in one patient population versus another, you can't make the same good decisions. There have been many spot sensors that have been developed for assessing tissue perfusion. So you may be aware of tissue oximetry, pulse oximetry, where you clip something onto your earlobe. We have our distinguished colleagues from Massimo here that have pioneered this in medicine. That tells you a lot about the central delivery system, so how well your heart and lungs are doing. But at the tissue level, there have been fewer tools, and recently there have been some developed that allow you to put a spot sensor. These are optical LEDs or lasers that are sending light into tissue, going through the complex light transport that you're learning about, being detected either by a sensor right on the tissue or by an optical fiber that relays it to a detector. And so there's computational strategies for doing that accurately. But from a measurement perspective, there are also downsides. You have to know where you're going to put the probe. If you put it in the wrong place, you won't see a problem potentially. The other thing is it's in contact. So if there's situations where there are needs to stay in a sterile field and you don't want to touch the tissue, that has its downsides. And one of the reasons that we want to develop new tools is that there is a big challenge in the healthcare system for containing costs, but also improving outcomes for patients. Let me give you an example. In chronic wound assessment, measuring diabetic or predicting the formation of diabetic foot ulcers. Right now, the cost to treat a diabetic patient that has a sore on his foot that won't heal gets non-linearly more expensive as the disease progresses. And the problem is that right now, treatment happens basically out here in the more aggressive form of perhaps surgery, perhaps drugs, but usually things degrade to where they can really need amputation. And the problem is, you get a stub on your foot, you can't feel it because you have neuropathy in your feet. And so a wound progresses to the stage where by the time you see a doctor, it's really too late. And the question that doctors have on day one when they see patients, or before they see patients, would be, is the wound site receiving oxygen? Is there perfusion? Is it healing? And they're unable to do that right now. And the average cost of amputation is $45,000 to $70,000. It's obviously very catastrophic for the patient. And avoidance of these things would save about $20,000 per wound, and that's probably a low estimate. Where simple intervention like advising to get better shoes or tie your shoelaces, and forcing that through the healthcare system would potentially avoid a lot of those injuries. And the reason we're interested in it as a company is because it's a huge market. There's a big opportunity to reduce costs in this segment. So the solution that we've developed, and I apologize, I'm talking about SFDI, but I'm going to take a step back in just a second. I just want to give you some context. On the day of surgery, we create a wound, and there's blood flowing in from this side of what we call a flap. The tissue's been raised and lowered, so it's only connected through here and then sutured back down. We can take a picture on day one or day zero and measure where the oxygen is. And then we've shown through various validations, which I'll talk to you about later, that you can predict exactly where the wound is going to occur. Now, this is a model that was designed to be an aspect ratio is too long, such that there won't be perfusion here. And what you see, we do see that it's hypoxic on this end, it's healthy on this end, and that's predictive of histological-based validation in the end. So that's the nutshell of the applications that I think about from day to day. And now I'd like to take a step back and just talk about tissue optics in general, and do that through images of this subject's face. This is a picture of a face with illumination at various narrow bands from 400 nanometers all the way down to 850 nanometers. And what you can see right away is that the spectral contrast changes dramatically depending on what color of light you look at. So what you see in 400 nanometers is a lot of contrast from, well, certainly hair, but all of the freckles and moles that are right there superficially on the surface. So that's melanin. Melanin is absorbing those photons. As you go through the visible, you notice that the light becomes a lot blurrier. The camera is just as well focused, but the light is much blurrier. And that's because the absorption is lower and the scattering is lower, and that means the photons can go a lot deeper into tissues before they come out. And the impact of that is that the photons go around and they basically do optical smoothing for you. So when they come out, you see deep structures like the roots of the follicles. I had shaved this day, but it was about 5 o'clock. So as time goes on, I bet the contrast would move north. But you can see the deeper tissues, but all of the melanin contrast is gone because the superficial tissue contribution of that signal is much lower. Please, yes, it was an LED source. So the question was, just for the recording, what kind of LED source was that? And it was an LED source with about a 20 nanometer full width half max at each of these wavelengths. It varies slightly between wavelengths, but that's basically it.
And the launch is going to be wide.
Yeah, and the launch angle is broad. So this is planar illumination. We're shining light everywhere and just looking at what comes back. And it's further uncalibrated, so it's just illumination with the field of the LED, which might be roughly Gaussian. Thanks for the question. And that reminds me, please do ask questions if I'm skipping over things or you'd like more detail about anything in particular. If you look at the things that absorb light in the visible and the near infrared, and I apologize if you've seen this slide again already, but the proteins and water absorb, in the UV, the ultraviolet here. This is wavelength plotted on a log scale. And between the dotted lines, that's the visible spectrum where you can see that melanin, oxy, and deoxyhemoglobin are absorbing. And then in the near infrared, you can see that water is kind of the primary absorber. And we have this opportunity to see very deep by this near infrared window here between, let's say, 600 and 1,000 nanometers that allows us to go as deep as possible. So we have contrast from these chromophores, but we also have contrast from tissue scattering, and that's what makes things so interesting and challenging. So as you know, in absorption spectroscopy in a lab where you would do a spectrophotometric measurement of the absorption peaks of a dye, you'd put the dye in a cuvette, the light goes straight through and absorbs the light in a linear fashion. You can use Beer's law to calculate the concentration of chromophores based on that. But when you have tissue scattering, as you know from this short course, the light goes where it wants. It scatters many times. It could scatter hundreds, thousands, tens of thousands of times before it reaches your detector. And there is a Beer's law happening for each one of these photons, but you don't know what path length the photon went when it arrives at your detector. So these coefficients, absorption and reduced scattering, and if you were to break up reduced scattering further, that would be the scattering cross-section, so how often things scatter, and then the polar distribution of scattering directions, which can be represented compactly by this anisotropy G factor. These are basically the two components that need to be separated in order to basically turn your tissue back into a cuvette and do absorption spectroscopy with mu-A. And there's many ways to create instruments in geometries to capture this information that might help you separate absorption and scattering. You can put a source and look in a transmission mode, or you can look in reflection mode. It depends on your application. I'm going to talk a lot about reflectance today, and I'm going to talk a lot about surface mapping of optical properties. So we could do also volume reconstruction where we have a 3D representation of absorption and scattering. That's what I'd refer to as tomography. Today, you'll see mostly 2D maps of absorption and scattering or chromophores, perhaps with some layered depth resolution. So when I think about measurement of optical properties, I think about how you put the light in and how you make measurements of the light. So there are roughly 4 quadrants, 2 of which we'll focus on today. On the left-hand side, we have spatially resolved techniques. So this is where I take this laser pointer and I send a light beam in, and I measure a point spread function. So if I shine a delta function in, what resolves back in reflectance or transmission is a point spread function or a diffuse reflectance that has this shape, and I can make a measurement versus distance, and I can make this measurement with a camera or a series of fibers that are radially distributed from the source. There's various ways you can do that. And there's also time resolved techniques where you send a pulse of light in time. So that's also a delta function, but it's in time. So that'd be a very quick pulse, maybe a nanosecond. And then you would look at how that pulse evolves from the tissue. And so these are, classic techniques that have been used to derive a signal where they can use the time-based or distance-based contrast in order to pull out the differences between absorption and scattering in that sample. Basically make multiple measurements to resolve multiple coefficients. And you'll hear a lot about that in Carol's talk next. On the top this is the real domain. So on the bottom, there's an equivalent way to make measurements with various experimental trade-offs that we call the frequency domain. So from a engineering systems perspective, if this is the point spread function on the top, there's a modulation transfer function on the bottom. And so in the time domain, instead of pulsing a light in time, you would modulate the light in time and look at the damping of the modulated waves as they remit from the tissue as a function of time frequency. And these are related by a Fourier transform. So you can go back and forth between these domains, either experimentally or computationally, and take advantage of one or the other. So if you have limitations in instrumentation, it might be advantageous to do a frequency domain approach. If you have limitations in modeling, it might be advantageous to make a time domain approach and then do a Fourier transform and only fit data in frequency regimes where you feel confident for your model. So there's another quadrant here, and that's what spatial frequency domain is designed to answer. It's measuring the modulation transfer function K in space. So we shine patterned light. Instead of pulsing them in time, we move photons in space using a projector just like I'm using here, and measure the MTF as a function of spatial frequency. And to give you an idea of the figures of merit for these time scales, we usually, and scales in general, a couple millimeters to tens of millimeters is relevant for many optical property separation problems. And so conversely, zero frequency, which is a planar wave, all the way to 1 per millimeter, which is fairly low from a projector standpoint, are the spatial frequencies that we are concerned with. Often these time decays are in nanoseconds, or a small number of gigahertz at the most. So focusing on the spatial domain for a second, we're going to measure the spatial point spread function. So we send this delta function in space, and it diffuses out into this blob. So if it looks like this when it goes in, it looks like this when it comes out. And then you can use various models to represent this curve, and you can compare your measurements to the model. This is an example in the virtual photonics tool where we have a model based on Monte Carlo simulations where the light is propagating with a pencil beam, and you can see that the light is going in directionally, but then it's also diffusing outward. And what you measure on the surface is proportional to the light just beneath the surface. The light beneath the surface I might refer to later in the talk as the fluence, and the detector would measure the reflectance. The question is, where do you put your detectors? And how many do you need? So how many, do I need 1, 2, many? And the key to answering that question in all domains is to understand your sensitivity and your selectivity. So the first issue is to make sure that when you make measurements, the thing that you're expecting to measure actually changes as a function of the independent axis that you're varying here. So as you vary absorption and scattering, this is an experiment where scattering is kept constant and absorption is varied. You can see that the diffuse reflectance as a function of the distance from the source, it decreases as you increase the absorption coefficient, and it decreases at all distances. Here we can vary the scattering and keep the absorption constant, and you can see different behavior where it looks like the contrast is mainly at short source detector separations, but not as much at long source detector separations. And if you look a little bit more in detail, there's some more interesting things that pop out. First of all, there's a lot of complex behavior right near the source in the first millimeter or so. So whether or not that's relevant to your application, it's important to understand. But more interestingly to me is this idea of scattering. So when I put a green laser pointer and I look close to the source, I have a lot of light. And if I think of high scattering as like, whipping cream. You know, you look at whipping cream, it's like bright white, or the paint on the wall. There's a lot of light that comes back, and the light is very isolated and focused. So near the source, a lot more light comes back when there's high scattering. But conversely, a laser on the wall, there's very little laser light that comes back 5 millimeters away because it's all really confined to that space. And by the time the photons have gone that far, most of them have been absorbed. So this is an interesting contrast that near the source scattering has differentially higher contrast, and then away from the source differentially lower. That gives you a hint that maybe you can separate absorption and scattering because these curves in log space look so different. Secondly, you need to think about depth selectivity depending on your problem. So if you have an optical fiber that's delivering light and detecting it, you can imagine that the light is not going to go very far in depth. It's going to have to be very localized in X, Y, and Z. If you put two fibers very far from each other, you're going to select photons that go much deeper. You're still going to have a lot of sensitivity right underneath your source and your detector, but the photons will convey tissue properties from deeper tissues. So, our field takes this in various directions. You can make multiple measurements at different distances and assume that you have a homogeneous medium, if that's appropriate for your problem. And then you can use the spatial dependence to calculate the optical properties. Sometimes that's not good enough. Sometimes you need many sources and many detectors in order to do lateral and depth sectioning. So there's a direction that you can take spatial domain measurements, which is to do diffuse optical tomography, where you place many sources and many detectors, you have many banana functions, and then all together you reconstruct a 3D volume. Now this is where I put my very opinionated hat on, and so I'll state my opinion up front. But there are a lot of challenges in this domain that I struggled with as an undergraduate and graduate student here at UCI. It's difficult in many cases clinically to assume that you have a homogeneous medium. So you have layered tissue where melanin is strongly absorbing at the surface. You have papillary dermis that is right beneath that is conveying things like infection, erythema. You have deeper blood contrast that's conveying information about blood pooling. You have changes in tissue remodeling that can happen at various layers depending on if it's skin cancer invading the basal membrane or if it's a burn that has a phase change of collagen. And so if you design a single probe and you say, well, I'm going to have 4 source detector separations from 2 to 6 millimeters and try to reconstruct absorption and scattering, this heterogeneity can cause a lot of havoc in your reconstructions. And moreover, it's also challenging often to provide an accurate model that that fully represents where the light goes, even in the case where it's homogeneous. So this is an example of comparing Monte Carlo simulations to the standard diffusion equation. And what you see is that close to the source, that the standard diffusion equation and the Monte Carlo simulations strongly diverge. And there are computational advantages of doing something simpler like a closed-form standard diffusion compared to Monte Carlo. But on the flip side, Monte Carlo can be more accurate. And then there's cases, like Vassen's lab is demonstrating, where Monte Carlo alone, scalar Monte Carlo that doesn't take into account interference, is inaccurate, and then you need something even more complicated. So there's a wide range of approaches and a wide range of problems, and I won't get too much into detail of them today. But the modeling is a big issue. Localization and optical property separability. Are you trying to get stuff in deep tissue or close to the source? Signal to noise ratio and dynamic range have been challenges for me. And in terms of optical probes, you can often place a probe and wash out the blood just by having pressure. Optical fibers get stepped on, they break. Often commercial devices don't even have optical fibers. They basically have disposables where they throw out sensors every time because they can't have fibers in a durable medical device. And calibration requires you to do deconvolution in space, which can be hard if you have a small number of measurements. Normalization is often an approach for a simple way of calibration, but you often lose contrast if you go from an absolute scale of diffuse reflectance to just a normalized scale where something is relative to the reflectance at a certain distance. Nevertheless, things have been developed that use these approaches to make real judgments of tissue perfusion in medicine. Hutchinson and Vioptics have created devices that are point probes. You can place them on the surface. They measure versus time. There's more today than there was than ever. Devices like this, but these were the first pioneers in that space. As we've discussed, there's limitations to assessing, just a point measurement, and there are many imaging systems available for wide field assessment where you don't have to judge where to place a probe. They all have limitations. So does SFDI, which I'll tell you about. But for example, you can do wide field illumination with just broadband LEDs and look at qualitative color pictures. Canfield Scientific has a very nice calibrated color photography system, and they have some derivative metrics based on transforming RGB pixel space into things that tell you a little bit more about blood or a little bit more about melanin, but they have their limitations. Hypermed developed a device that used a liquid crystal tunable filter and made many measurements throughout the visible in order to assess tissue perfusion, test tissue oxygenation. A limitation of visible light is it doesn't penetrate very deeply, and many wounds occur deep in tissues, and by the time it reaches the surface, it might be too late. Novadak has a system that allows you to inject a fluorescent agent into the bloodstream, and you put a surgical drape and you look with a camera and illuminate with one wavelength and look at a different wavelength and see how much light comes back and versus time. So the fluorophore washes in and washes out, and that's one way to assess perfusion. Again, that's effective in medicine for a certain number of cases, but it's also challenging in ways in terms of having to create a surgical system that, in surgery, everyone stops what they're doing, puts a drape on, makes this measurement that takes a few minutes, and going back. We'd like to be able to build systems that perhaps can just integrate right into the surgical field and not affect the workflow. So we developed, Vasan, question.
Since you're transitioning from spatial domain to SFDI, maybe this is a good time to pause and just solicit some questions, especially since you went through the foundations of spatial use.
Yeah, absolutely.
It seems like you're going after oxygenated hemoglobin and looking at the oxygen, and it seems that the short wavelength end of that is a substantial problem with melanin. I'm just wondering if you're trying to get away from the melanin problem, or trying to correct for it, are you actually going to be like trying to calculate the melanin and then correct for it, or do you look at the idea of somehow moving the wavelengths to a longer wavelength so that that doesn't happen?
Thanks for your question. So to repeat it for the audience, for the recording, it's how do you calculate tissue oxygenation in the presence of melanin with visible light, or do you selectively choose the wavelengths in order to avoid the melanin contrast? That's a great question. I've probably spent the last 3 or 4 years of my life fretting about that, and I'll tell you a little bit about how we approach it. Effectively, we found that in the early days we wanted to avoid the problem by putting just using near-infrared light, but even that wasn't good enough, and we've since then added visible light in combination with near-infrared light in order to more fully characterize the problem, where we calculate melanin, oxy, deoxyhemoglobin, and water and scattering all simultaneously. And so to measure one, we like to measure all.
Other questions? Is everyone fully comfortable with the absorption and scattering contrast that David showed with respect to keeping scattering fixed and varying absorption, and vice versa, the different qualities of this spatially resolved signals?
So I'll talk about wide field imaging, but I'll talk mainly about my favorite version of that, which we call spatial frequency domain imaging, or more generally structured light illumination. We found that adding spatial contrast over a wide field allows you to keep quantitation that you have in these near-infrared probes. This is a diffuse optical spectroscopy device here at the Beckman Laser Institute, and translate that to multiplexed spatial measurements, but retaining as much quantitation as possible. Different limitations in terms of the geometry of detection. Typically, these will measure deeper than you can measure with a camera, and this spatially multiplex method I'll talk about. But that's been our passion, is really to apply these quantitative methods in the real domain to the spatial frequency domain in a way that allows us to multiplex in space. And so here's an example of another subject, Fred Ayres, that is being illuminated with blue light. And you can see how this works. These are spatial patterns of sine waves that are projected onto the surface of skin, captured with the camera, and then analyzed. And we call that spatial frequency domain imaging. The reason that you'd like to do that are manyfold. Here's an example in neuroscience. So in neuroscience, if you inject potassium chloride into the cortex of the brain, and you thin the skull, so the brain is intact, and this is in a mouse, but you can see straight into the brain. What will happen is that you'll generate a cortical spreading depression wave. We looked with 4 wavelengths and 2 spatial frequencies and made 6 seconds per measurement for 35 minutes. So this is a sped up video. And you'll be able to see the contrast, hopefully. This is my laptop that played earlier. I apologize. Well, what you would have seen, and hopefully I'll fix this for what gets uploaded, but is that the oxy and deoxyhemoglobin wave propagates through, and you can see the exchange of oxygen as the brain struggles to keep its cells healthy. But what you also see is that the scattering wave propagates in a very coherent way that's completely independent spatially from the oxygenation wave. And so it's very interesting to study these things in isolation, because you can then make inferences about physiology. If you measure the scattering, you can be better about the path length so that you know these values are correct. And actually for this neuroscience problem, it was very interesting to be able to isolate the scattering, because we could directly visualize the hyperpolarization and then the depolarization of the neurons as this disease progressed through the skull. So the fundamental principle that SFDI operates on is that tissue is a low-pass spatial filter. It's tissue's blurry, and we saw how it got blurry by putting a point and seeing it blur in space. This is similar. If you shine a wave with some structure to it, that structured wave will propagate in Z into the tissue, and the amplitude of the structure will decrease over time. And that's because photons are constantly scattering back and forth laterally and basically removing the contrast from this wave, so that by the time it gets deep, everything's kind of averaged out. And we refer to the diffuse reflectance, RD of K, as the basically what comes out. But what's inside the tissue in terms of the amplitude is the AC fluence rate, the fluence rate of this AC component. And we can plot that here. So here's fluence rate versus depth for a specific spatial frequency. This is the lowest frequency, it's planar. And as you increase spatial frequency, what you see with the fluence rate is that it decreases in amplitude. So it's a low-pass filter. High frequencies are damped more than low frequencies. And moreover, the depth dependence is different. So in terms of the first component, the wave is damped, and what we measure at the surface is proportional to those measurements just beneath the surface. So those 4 blocks are basically those 4 blocks. So we make measurements at many spatial frequencies, and then we fit that to an equation that represents what we believe absorption and scattering contrast should produce, and we get a curve like that, and that allows us to quantify optical properties. So you'll hear about inverse problems in Carol's talk and kind of the trade-offs in choosing numbers of detectors, distances of detectors. But today I'll just focus on basically sensitivity and separability of these 2 parameters. So this is the spatial modulation transfer function. The diffuse reflectance is the MTF. And this is what those MTFs look like when you vary either absorption on the left or scattering on the right. So I'm plotting diffuse reflectance versus spatial frequency again. You can see like this frequency is 0.1 per millimeter. So that's a 1 centimeter period. And what's interesting is that when you go from low absorption, which is this top curve, to high absorption, there's a lot of contrast here at low frequencies. Conversely, at high frequencies, there's very little contrast between all the waves. They all kind of converge for high frequency. When you vary the scattering but keep the absorption constant, you see something completely different. That when you go from low here to high, the overall reflectivity is broadband at all frequencies. So this difference in the contrast between absorption and scattering is fundamentally what allows us to separate those 2 chromophores. But before we talk about that, I'd like to talk about length scales. So if you think about low versus high frequency, the inverse of those are length distances. So at low frequency, 1 over 0 is infinity. And so 1 over 0.1 would be 1 centimeter. And here we're at very, very short spatial distances. And you can imagine if you're a photon, that when you're traveling at least through the infrared, where things are very turbid, that the chance of you getting absorbed is a lot lower than the chance of you getting scattered. So you're going to have a lot of short interactions with scattering, but absorption is going to take a lot longer distance for it to have its effect. So that's why at high frequencies, there's little absorption contrast, because the photons just haven't had time enough to get absorbed. For scattering happens very quickly, so it affects all spatial frequencies in a more broadband manner. Tom? Hi, Tom.
Sorry, I was a few minutes late, had to get gas.
No problem.
I just have a question about the y-axis.
Yeah.
Is that the total intensity, or is that the amplitude of the spatial modulation shown in this plot here?
That's a good question. So when we make measurements, we shine. So the question was, is the y-axis represent total intensity of your measurement, or is it just the modulated component? And the answer is just the modulated component. So if you think about DC for a second, planar illumination, That's on its own. You send light in. If you send 100% of the light in, you'll get, in this case, 78% of the light back. If you look at the modulated component on top of the DC of whatever frequency that's not DC, it's there's less and less and less. So when I represent diffuse reflectance, this is on an absolute scale for each frequency component. So there's a lot of calibration that goes into making sure this is an absolute measurement. Boston question.
So looking at these graphs, of course, this is in the spatial Fourier domain, and kind of a crude way of thinking about it, but not, admittedly not an exact way, is kind of the reciprocal of the spatial frequency is roughly correlated to kind of the characteristic source detector separation in some sense. And that's why in the absorption curves at small spatial frequencies you have the most sensitivity to absorption because you have the largest path lengths. And then of course close at large spatial frequencies you have less and less sensitivity. Now what I find interesting here is that in the earlier plots you showed where you held absorption constant and you varied scattering, close to the source you actually got increased signals for high scattering, but far away you actually got a reduction in the reflectance far away, and so you saw this crossover. But here you don't see such a crossover. Here you get broad increase in reflectance with increasing scattering no matter what spatial frequency you're at. So can you explain that? Because it's kind of an apparent, I wouldn't say contradiction because I know this analogy isn't completely proper, but could you explain that a little bit? Why you're getting a broad increase in AC reflectance across all spatial frequencies?
Yeah, thanks for the question. I'll do my best. So why in the real domain do you get a crossover in contrast from short to long distances for scattering, whereas for the spatial frequency domain, it's more broadband? There's a tie-in to spatially in Z where the light is going. So when you make a measurement at a specific source detector separation, you're doing a geometric selection of which photons are being measured. So you're choosing, there's going to be a conditional probability of illumination, visitation, and detection in that localized volume. So that geometry forces the crossover. Here, we're not talking about lateral dispersion at all. I could add in phase into these plots, and I'm not, but that's really where you would get that back, is the ability to play with these crossovers and sensitivities with depth. And the way you would do that is not to illuminate the tissue with a normal beam where the plane wave is going in normally, but instead illuminate the plane wave at an angle. And I haven't included that in this talk.
So the key thing is that in the spatial domain, by putting discrete sources and detectors, you are doing some sort of selective weighting in depth, whereas here you're integrating over all depths.
That's right.
Okay.
It's more observational as opposed to forcing it. You can still choose your wavelength, choose your spatial frequency to interrogate different depths, but at least from the context of a semi-infinite, maybe perhaps layered model, there's no ringing here. There's no interference with these scalar CW waves with depth structures. So the best you can do is get all of the light back. You add absorption, it subtracts, and if you add scattering, it just increases reflectivity at all frequencies.
Or another way of saying is that at large source detector separations, you actually are rejecting most of the light that propagates around the surface.
That's right.
Whereas here, you're collecting all of the light coming right from the surface.
Exactly.
And so therefore,
this is getting all of the light, yeah. So pluses and minuses. You can select where light goes by doing radially resolved measurements, or the light that you've detected at least. But the flip side is you might not be able to do well very close to the source because there's a lot going on. Any other questions? Yes, sir.
Just wanted to clarify, this is a CCD measure in the reflectance here?
It can be a CCD measure in the reflectance, and most of the time it is, yes. I'll talk through a few different embodiments of this spatial frequency domain instrumentation, but typically, and I'll show an instrument diagram in a second, it's a camera.
Oh, and unlike the fiber measurements, your course can measure every square millimeter of tissue within the range of the CCD collection.
Yeah, exactly. The camera and the projector can be mapped and scaled over a wide field or a short field depending on what you need. Yeah. Any others? Okay, so we're about halfway through the talk. I have a lot on validation and clinical stuff that probably I'll go through more quickly, but I think it's important to cover these fundamental concepts. So in this last slide, we talked about optical property sensitivity. So you can see that we're sensitive to absorption, we're sensitive to scattering, but we also talked about how there's a differential contrast between absorption and scattering. And one way that has been very useful for me, because I'm an experimentalist and non-mathematician, to visualize this contrast computationally is to draw isocontours of contrast. So our observable function is plotted on the two axes. So this is what we would measure on the diffuse reflectance for zero frequency, a planar wave. And just let's pick 0.5 per millimeter, a very high frequency, where we might do the best to resolve the contrast. And if you plot isocontours of absorption and of scattering, you'll notice that these are very, well, you might have to take my word for it, but these are very orthogonal squares. There are many measurements of where either the frequency is too low or the absorption is too high or the source detector is too close, where these things would be basically sandwiched on top of each other. So if you, in your particular domain, not even diffuse spatial frequency, but any domain, plot your observable functions versus the things you're trying to calculate and see exactly how orthogonal these things are. Please correct me if this is wrong, but this is if you think about the partial derivative of your observable function as a function of these two parameters, absorption and scattering, that tells you about the orthogonality of these lines. So what you can imagine is, if I make a measurement here and I make a measurement here, I can look up and get an exact value for absorption. There's a lookup table. We can use just two frequencies to calculate optical properties with this method. But moreover, if you imagine if they got squished and they were all sitting on the side, that maybe in the presence of instrumentation noise, you might be really good at getting diffuse, contrast in one parameter of absorption, but if you move just a few percent, and because of noise, you're in a completely different regime. You could be very sensitive to noise in that other parameter. So take a look. I recommend it. So back to tissue being a low-pass facial filter, we talked about how these waves are damped in depth and that at the surface they show a low-pass filter function versus spatial frequency. If we normalize the depth function, though, you can see that there's a difference in the depth interrogation volume of each of these frequencies. Fundamentally, this should allow us to do some sort of depth resolution or depth tomography by scanning the spatial frequency and perhaps in combination with scanning the wavelength. And I won't go into detail in my talk, but I will point to a few references that have been excellent at describing how you would do this diffuse optical tomography with structured light and with SFDI. And here are a couple of references. And the upshot is that you can get very high resolution spatial structures, just like you can with diffuse optical tomography. You can actually probably get higher resolution. There's fundamental papers by Markel and Shotland that describe the trade-off about sampling density and resolution. And it works, but working within the context of this is still a CW method. There's still a constant light. There's no pulsing in time. There's no modulation in time. And so there are fundamental crosstalk issues between the size of an absorber and the intensity of the absorption, the contrast. So what has been done in the spatial frequency domain historically, to give you a little bit of context, back in, a long time ago, people described how plane waves, before even Ishimaru, people described how plane waves propagate through the surface of the Earth for heat waves, those are time-based waves, but the same wave propagation applies in the spatial domain. But Ishimaru described the propagation of scattering in random media directly in the spatial frequency domain in 1978 in his book. And you can go back and look in K-space about how these plane waves propagate, get damped as a function of different parameters. And so for a very long time, there's been modeling of the spatial frequency domain for turbid media. David Boas and Alvin Kinley and Mark Helen Shotland all have described these waves and experimental techniques that make real domain spatial measurements and then transform into the spatial frequency domain in order to analyze their signals. There's also been spatial frequency domain measurement in diffractive systems. So you may be familiar with confocal microscopy. There's a specific flavor of that people call structured light microscopy. And this was pioneered by Mark Neal and Tony Wilson in 1997. And that uses a sine wave projection through a lens system. And they use the MTF of the lens as captured by the structured light in order to depth section. So if you're looking at a depth from 0 to 100 microns, you can tune this system to resolve the contrast only at 50 microns. It's a way of using the MTF of the lens in combination with the structured light to reject out-of-plane contrast. And that's, in some ways, a poor man's confocal pinhole, where you're moving the pinhole around. And it was very remarkable to see him present once where he took this very expensive confocal pinhole system and replicated the results by having basically a lighter with a light source and doing this structured light and getting very similar contrast. So there was very practical outcomes of doing structured light, spatial frequency domain measurements in this, and this was licensed by Zeiss. Later on, Georges Vanier and Nora Dognitz used the approach of shining patterned light, radial patterns, onto a turbid media. This was intralipid, and then captured that data with a camera. And then they took a spatial transform in their data set and did a Fourier domain analysis. So that was structure elimination and then SFD analysis. And so what we did was kind of go all the way and say, let's not project binary patterns of light. Let's not just model how the waves propagate, but then model point sources and detectors. Let's actually make a spatial frequency domain measurement in turbid media directly. Let's shine sine waves, and let's look at the amplitude and how it resolves as a function of frequency. So in terms of doing that measurement, it's fairly simple and very flexible depending on what you'd like to do. You need a light source. It could be a white light, or it could be a monochromatic LED or laser. You need a way of modulating that light spatially, so creating a pattern. That could be in an LCD or a digital micromirror device, a DLP, or it could be a slide projector. That was our first data. It was collected with a Kodak slide carousel. And you need to then detect the light that comes back. You can use a CCD, a CMOS, and another embodiment. You can use pinhole fiber or a single point detector. We also like to polarize the light, so there's a polarizer and an analyzer in order to reject specular reflection off the surface, and that makes it very practical for clinical applications where you have glossy surface reflections, and that does not convey anything about the subsurface light propagation. So if you have white light, you can also then do spectral filtering on the detector side. So you can look at individual bands with a liquid crystal tunable filter, a rotating filter wheel, etc. Awesome.
So I have a question about the polarizers. I know that certainly in medical practice, especially in dermatology, people actually use polarizers to alter or to enhance either contrast to superficial structures versus deep structures. And so the use of polarizers, even though it might help reject specular reflection, it also does reject some of your multiple scattered light from superficial structures. Mm-hmm. And so it seems as though on top of the spatial sensitivity or differential spatial sensitivity with depth that you're getting by nature of the differential damping of these spatial waves. You're now also introducing a second selectivity that is actually very dependent on the heterogeneity and the size distribution of the scatterers. What impact might that have on recovery of optical properties, since you're no longer integrating over Z in the way that you assume you are in the model?
That's a great question. So how does this cross-polarization affect our ability, how good is the assumption that cross-polarizing is not going to affect our results? And there was actually a paper at the last couple of months, I believe, that from, I think it's Alvin Kinlay's group, but I need to check, that describes the effect of polarization in the spatial frequency domain. So it's not trivial, but it's been very useful. And in fact, so you mentioned that you are losing some contrast from the most superficial tissues. For many reasons, that has been a boon to us, because our model of the tissue structure is effectively most inaccurate right near the surface, both because of having to know the angles of illumination, as well as having models that reflect, non-microscopic transport layers, and the fact that the photons, when they go longer distances, they're more diffused, so they average more tissue volumes. So it has actually selected longer path lengths, as you say, and that in general has been a good thing for us, but it's definitely something to add to better understand and better remove bias that you might be adding into the experiment. There's an instrument that was developed, in fact, to avoid having to do that by having two digital micromirrors in the surgical system, not for SFDI, but just in general for planar illumination. I thought it was fairly interesting that they would have a checkered pattern on the source and a checkered pattern on the detector that would be out of phase with each other. And so by alternating, they were able to do basically very microscopic source detector separations, and integrating over time, they get a wide field image, but they don't have to reject specular reflection. They don't need polarizers.
Yeah, perhaps a follow-up. I guess my concern is that you are on some level, or one is perhaps, if you're acquiring data in multiple spatial frequency, actually subtly altering the curvature of that demodulation. Mm-hmm. Because obviously the effect of polarization is going to affect things more at high spatial frequency than low spatial frequency, and then that could bias the recovered mu A and mu S prime that you get out.
It could, absolutely. To take a step back, there are many things that could bias us, and I point to another Kinlay paper recently. It talks about assumption of anisotropy, assumption of index of refraction, assumption of height. There's a lot of assumptions that we make, and the key is to try to peel the onion and make fewer and fewer assumptions over time, but retain your ability to still accurately resolve chromophores. So I apologize, it's kind of a hand-wavy answer. I totally agree that there's more to do, and that we would be biasing ourselves. One thing that saves us from just about everything is calibration. Calibration allows us to do a whole lot of stuff that probably we couldn't have done otherwise. Allows us to correct for MTFs of our detection systems, inaccuracies of our model, spatial distributions of illumination and detection, a whole lot of things. And calibration then allows us to orient this absolute measurement in a regime where we trust the results.
Thank you.
Thank you. So some benefits of this non-contact approach is that it's non-contact and it's scalable, so you can kind of back off, you can use wider angle lenses, you can, in the mouse brain, look at it over a centimeter or less over the back of a patient that's bedridden and might have bed sores. You could take a picture over a large field with various trade-offs in terms of resolution, sensitivity to absorption and scattering, etc. But it can be implemented with consumer-grade electronics, and more importantly than any of the top three, I think, is that it's just another axis. So it can be combined with any of the tools that you might be working with today, if you're not already working with SFDI. If you're doing fluorescence measurements, it might help you understand better the optical path lengths of the light traveling through the tissue. That might lead to better quantitation in fluorescence. It might allow you to do that at a couple different wavelengths to be able to calculate quantum yields, for example. For laser speckle, the same thing. It might allow you to either understand the path lengths of interaction to better quantify things like optical flow, or it might allow you to do depth sectioning of optical flow contrast. Hyperspectral, multispectral, as you've seen, you can do this at many wavelengths. So if you have a hyperspectral machine, you can just illuminate with a structured white light and do this at all the wavelengths simultaneously, and then go from just reflectance to reflectance versus wavelength and frequency. Polarimetry, I added that in there. It's certainly interesting to be able to build an instrument, SFDI instrument that got maybe the whole point Curie sphere. Okay, so I'm backing up a little bit, but I wanted to give you an idea practically about how a measurement is made. So we talked about how these waves propagate in, and you measure them at the surface. But as was mentioned, with a camera, you can actually measure this wave at multiple spatial points. So you see this wave evolve from the surface. And I have it spatially varying here. Maybe there's something underneath here that's damping the wave more in the middle than on the sides. So we project one sine wave in our classic way of doing SFDI. There's many ways to do this, but essentially what we want to do is envelope detection. So a simple way to do envelope detection is to phase shift and shine 3 separate patterns, take 3 separate pictures. So here are the 3 images, 1, 2, 3, and each wave is offset by some multiple of the period. So this is 0, 120, 240. You could also break it up into arbitrary phases of at least 2 or 3. But up to 5 or 6 if that's useful for making more accurate measurements. And then what we want to capture is this envelope function. So you can kind of see it forming in your eye, but it's very simple to calculate the amplitude of that AC wave independently from the DC wave that's being also projected at any given time. You see that there's always a DC offset here and then an AC writing on top of it. Light can't be negative, so you're always going from 0 to 1 coming in and less than 1 coming out. So you have that DC offset here, and by doing this demodulation, which is just subtracting each, at any given pixel, subtracting each separate image from it, the other one, squaring that, adding it together, and taking a square root, you could get this envelope function that varies in space. I plot space in X, but this extends to X and Y. So then you get a 2D map with a camera and a projector. And this is what that looks like in real life. Here's a DC image. Here's 3 AC waves that have the same spatial frequency but are separated by in phase. We demodulate the amplitude of these 3. We propagate the DC, and then with at least 2 spatial frequencies at every pixel, we can fit that to get a measurement at every pixel of absorption and scattering. And we can render that in 3D as well. I believe that's here. So in addition to using structured light to capture the SFD, spatial frequency domain, diffuse signal, we can also see the phase of that wave as it bends around tissue surfaces and capture the 3D structure with a measurement called phase measuring porphyrometry. And this was the work done with Sylvain Giou's group and John Frangioni's group at Beth Israel Deaconess Medical Center, where we showed that with the same instrument we could also reconstruct phantoms at different heights and different angles accurately. So this is us just overlaying a tissue oxygen saturation map calculated from these these absorption values at multiple wavelengths on top of the 3D structure of the face. So if you make measurements of absorption at multiple wavelengths, you're now back into the cuvette mode, and you can do linear absorption Beer's law spectroscopy to calculate oxy-deoxyhemoglobin tissue saturation. If you measure here at 970 nanometers, you can calculate water fraction. There's also interesting things to derive from the wavelength-dependent scattering signal once you have it. If you fit a power law decay, you can get an idea of both the cross-section, the overall number of absorbers with this prefactor A, and then the wavelength dependence of the contrast B, which would tell you more about the density of the scatters and the size of the scatters. I'm sorry, the A would tell you more about the density and B would tell you more about the size. talk for a second about calibration, I mentioned it's my favorite thing. These are some of the problems that can be solved with calibration. You can correct for the point spread function of the MTF of the optics, inhomogeneities in the beam that you're projecting with, the spectral dependence and the temporal response of both the emission side and the detection side. And all of those things are happening all at the same time. But luckily in the frequency domain, calibration is actually very simple. Whereas in the real domain, you have to deconvolve the PSF from your measurement. You can, in the frequency domain, divide out the MTF in a linear way because every frequency behaves independently of the one next to it. So if you think of a measurement, an AC measurement, at a specific spatial location and a specific spatial frequency, that's the illumination function of the LEDs, then going through the transfer function of the system, multiplying that effect through the system, and then so decaying the wave not because of the tissue but because of everything else. And then you have the actual diffuse reflectance, which is the MTF of your tissue, and those multiply 1, 2, 3. So if we solve for this component here, you can see that we can take a ratio of the measurement, MAC, and divide it by the diffuse reflectance and come up with a system transfer function. And this thing can be used to calibrate other measurements. Well, it can be as long as you can get this number. So we can make this as a measurement. Diffuse reflectance of the reference would be a calibration phantom of known optical properties. So we have many of those in various forms, but often there's either silicone or let me just say silicone based phantoms and with absorbers and scatterers that are designed to mimic the optical properties of tissue. And if you can know those properties well, you can put those into your model, calculate a diffuse reflectance, and come up with this ratio. And that ratio can be used to calibrate all of your data. Any questions? Tom?
Just backing up a little bit. Sorry,
Yeah.
there's a bit of a phase delay in my head in processing all of this. When you were showing the plots of the modulated reflectance as a function of optical properties, there was no talk about multiple phases in an envelope function. Could you perhaps just back up a little bit and explain again what that's coming from and why we have to do the multiple phases?
Yeah. So why do we do multiple phases? First of all, so the answer to that question is it's one way to calculate the envelope. This is a historically time domain approach where you phase delay in time 3 waves coming through wires, and then you use circuitry, to do this math in hardware. And we adopt that in space instead. So this is the Tony Wilson approach for microscopy we adopted for diffuse imaging. And we just project these 3 waves, and you have 3 numbers where you don't need to know the frequency. You just need to know that they're offset in phase by 120 degrees. And you can do this simple math to get an envelope function at every pixel. So that's why we illuminate with multiple phases. Now going back to excuse me, it's a little slow. Going back to these plots, these were the contrast of absorption and scattering versus frequency. There's also phase hidden in these plots, which is the native phase shift of the wave due to the tissue. And it is exactly 0 for all of these measurements because we're illuminating straight on. So if we illuminated any given phase and frequency from an angle, you'd see a lateral phase shift as a function of frequency as well. And that's not here. Does that help? Boston?
David, maybe I'll try and help your case as well. Can you go back to that diagram with your envelope your 3 phases?
Yeah.
in the next, right, so in the diagram that you have on this right-hand side, if you look at it, you say, well, I didn't really need those 3 phases. If you just take that first one, I can kind of see what the AC is. And the reason why it looks so easy here is because you've kept your DC constant across the whole field.
Sure.
In reality, your DC can be changing at the same time, and then extracting the AC from the DC may not be so straightforward just by taking one current. In fact, to do it mathematically rigorously, you have to extract it out. You need at least 3 measurements.
That is true. The DC here is constant so that you can see the AC isolated with your eye. If you took a mean across the entire image, you could just subtract out that mean and just get the AC modulated component. You'd still need to get an envelope function, so you'd have to remove the oscillation, but it would be simpler. 2 caveats, so 2 comments about that. One is, you don't need to do all 3 phases. You could do 1 phase projection and do other envelope detection methods. There's single sideband demodulation that requires a Hilbert transform, which basically takes a sine and transforms it into a cosine, and you combine them together to get an amplitude assessment. There's various ways to do demodulation. This is just a very simple one. Kyle Nadeau just graduated from Bruce Stromberg's group, and his strong focus of his dissertation was on other ways to do this. Because you imagine if you have to take 3 pictures, it takes longer, and maybe the subject moved. So if you want to go fast and you don't want to be as sensitive to subject motion, fewer is better. The other thing I will mention, just because it's a virtual photonics talk, is that when you mentioned that the DC may be varying, that's an interesting problem statement, because if the DC is varying, it's not DC. So that is also, if the DC is varying, then it is not constant in space. So there's actually a frequency component to the average value. If you do a narrow window, you can say the average value in this window is X, right? But if you, in this we're varying, if you moved over a window, it might be Y. But if you change the window size, those 2 DC values would not correspond to the DC of the larger window. So if you did a full wavelet transform of the data that comes back, what you'll see is that there's variation on all spatial scales, and you're limited by the method. So right here we're assuming that everything else is constant, and that DC is truly constant, but it's possible it's not.
Yes, but in reality, you are reconstructing different optical properties for each value of X. And so therefore DC is on some level I agree that the processing assumes that DC is not varying, but implicitly, if that's the case, then your optical properties should be uniform across X. And clearly you're reconstructing images where your optical properties are varying along X.
That's right.
Okay. So there's kind of you can't have it both ways on some level, right?
That's right. I need to get better at explaining that. Thank you. Gordon.
Is there not also a practical consideration in that if you're only to use 1 phase, you have areas where you have 0 illumination?
Yes, absolutely. So if there are fundamental trade-offs, if you use fewer phases to project, then you have much poorer resolution with which you can reconstruct or separate AC and DC. Yeah, and exactly right here, if there's very little light coming back, your ability to calculate something at that pixel is impossible, but you need to find a window over which you felt comfortable calculating that amplitude. And the larger the window, the more confidence you have in the value of the amplitude, but then the less confidence you have in the localization of the signal. Okay. I'll talk quickly about hardware and some of the trade-offs and trade spaces. This is an example of the development that we've gone through. This was a system I built in the lab. It's lovingly called MI2, and it is a liquid crystal tunable filter camera and a broadband light source. It's been improved in its looks over the years, but essentially it's been the same, and the workhorse instrument allows us to look at any wavelength from 650 to 1,000 nanometers and do SFDI. We'd wheel this into the clinic. It'd be very difficult to make measurements on arms. When we got funding through SBIR grants at the company, we were motivated to create hardware and software that would make an SFDI measurement more reliable in the clinic. And the reason we wanted to do that is to be able to go out and validate our market assumptions to build a device for medicine. So we wanted something that we trust the data that came back, and it would be something feasible for a nurse or a physician to use. And so the first generation looked like this. It was a box about this big, and it had near-infrared wavelengths only and a color camera. And then the second, the phase 2 grants allowed us to build something even more clinic-friendly that you see there. So it's a touch-based tablet. This is just a uninterruptible power supply, and all the computing is done here, and all the hardware is here and talking to the computer over a USB cord. But to get there, we had to answer fundamental questions about, what are we trying to optimize for? We wanted to optimize for size. We wanted to optimize for clinical environments where there's subject motion. We wanted to, and where there's ambient light. So we needed high power light that could overcome the ambient light. We needed to make the measurements fast so that there was not any registration requirements of our images. And it turned out through a series of studies that we really only need 2 frequencies in order to really resolve absorption and scattering. So that was good. Typically in spatially resolved measurements, you need a lot more than 2 in order to be able to accurately resolve absorption and scattering. The question was how many wavelengths? When we were talking about just isolating oxy and deoxyhemoglobin, the answer was also 2. Over the years, we've added wavelengths in the visible to be able to resolve melanin separately, and now in our clinical embodiment, we have 5 wavelengths. There's been work done, to evaluate the limitations of the models, and allowed us to put our measurements in context, our clinical measurements in the context of these limitations when you assume a Henry-Greenstein phase function versus a Mie scattering phase function versus others that are available. And it was illuminating to understand kind of the regimes that we're in and why some of the things that work and some of the things that don't work. We also evaluated the effect of tissue curvature for this instrumentation. As I mentioned, we're able to capture the 3D surface. What you see is that when you vary the height of a sample, the scattering that you would collect, assuming what perfect height you're at, it varies, and absorption is even more variable. So just moving the sample in and out of focus can dramatically change the results. Moreover, changing the angle of the tissue can even more dramatically change the results quickly. Absorption and scattering are both affected. So by developing a method with Sylvain Giu at the Beth Israel Deaconess Medical Center, we were able to capture the surface of the surface shape and go from measurement of this phantom where we assume a homogeneous model, and it is a homogeneous phantom, but we're actually getting wildly varying hundreds of % error in the side lobes of this hemisphere to just a few percent. 7% was the metric we came up with for this specific phantom. So dramatic improvement in the clinical utility by being able to do that calibration. The other thing we worry a lot about is this phantom calibration in terms of how well you know your phantom optical properties. These are examples of tissue phantoms, and there's many ways to characterize them, and every measurement technique will tell you a slightly different answer. So it's a fun problem to kind of go in circles for a while and figure out what you trust more. Inverse adding doubling is classically a really good way to do phantom characterization if you can create a thin sample also. That was described, I think, probably in this lecture. Yesterday, perfect. Spatial frequency domain imaging is an emerging approach that might be really good for characterizing phantoms. Diffuse optical spectroscopy has always been the thing that we went back to as coming from the Beckman Laser Institute. We have these very quantitative time frequency domain devices that allow us to do it. And then also SMOCS, spatially modulated quantitative spectroscopy, more recently rephrased as spatial frequency domain spectroscopy, SFDS, is very interesting for this because it allows us to do SFD at every wavelength. You can also guess, so you can say I'm putting this much of this stuff, this much of this stuff. If I measure this absorber in a cuvette, I get this number, and I add this much scatterer. In this situation, I get this, and then you can kind of assume that they merge together correctly. And that's usually the worst choice you can make, is to do that. There are other instrumentation embodiments depending on trade-offs. So I immediately went to camera. Oh, I'm sorry. Did you have a question? Oh, okay. I immediately went to camera-based detection, whereas with fibers we were just looking at a single point. All of a sudden we had 1 million pixels, and we were processing data and getting absorption and scattering versus space. But this can be done with a single pixel as well. So imagine your camera only had 1 pixel and it was only focused at that one spot. You could still project spatial frequency domain waves and do that single pixel demodulation we talked about with the 3 phase shifts and get an assessment of absorption and scattering just at that one point. And knowing that, you can extend that to, well, what else would I do with my instrumentation if I was liberated from camera optics? What could I do? And one of the things you could do is put that point into an optical fiber, and instead of just measuring one wavelength at a time, you can measure all of the wavelengths at the same time. And so this was work that we did with Rolf Sager and Tony Durkin. Lovingly coined SMOCS, but it's spatial frequency domain spectroscopy in the context of this talk. And so here's some raw spectra. This is calibrated diffuse reflectance spectra versus wavelength and frequency. So this is the low frequency wave and the high frequency wave. And you can see that the low frequencies have these dips and peaks. That's a water peak. Low frequency is very sensitive to absorption, and that's absorption of water. You can see a high frequency waves are only sensitive to scattering, so they're really just giving that scatter log decay contrast. And we can then take this data set and calculate absorption and scattering with high spectral resolution. You can take that a step further and say, well, I've unburdened myself from having a camera so that I can do spectroscopy on the detector side, but I've still projected, let's see, I'm still only capturing a single spatial point. That's the point I want to make. I'm still just capturing this one little point here. What a group in Canada did, this is Frederic Lesage and Xavier Entes, they came up with an approach to use a spatial light modulator, a DMD, on both the illumination and the detection side. So they're able to project light over a large area. In this case, they were doing a transmission onto the sample, but you could do reflection as well. And then on the detector side, they still have a single, on the detector side, they have a single sensor like we did here, but that sensor is being modulated by a DMD. So that DMD is actually projecting a sine wave itself, or what other structured light wave you'd like. And it's doing a instrumentation, an optical transform of that whole harmonic wave across the entire space and giving you a single number. So they're able to get an assessment for the amplitude of this plane wave over the entire field by just making a single measurement by doing spatial selection with a DMD. And the benefit to this is that you can use very sensitive detectors. You can add time domain. You can cover large areas over very, very quickly and do full 3D optical tomography, perhaps even with time domain contrast as well, with a point source and a point detector.
So I'm a little confused. How do you get spatial resolution from this technique? So I didn't quite understand exactly how you select different locations on the object, because you said you could get 3-dimensional or 2-dimensional.
The way they do it is by through the basic concept that your visual field is a linear superposition of plane waves of various frequencies and phases. So they can measure any plane wave they want in X or in Y with any phase and frequency in order to reconstruct a data set that represents the full field. And so if you shine with a sine wave and then you detect with that same sine wave feature, you basically multiply out all the rest and you just get the sine wave back. So you get the assessment over the full field of that one plane wave. I know I'm running out of time. I will talk just generally about each slide so that you'll have a reference for when you look at them online if it's interesting to you. We've validated this technology at various stages. This is in a cuvette where you add yeast into blood, and then the yeast eats up all the oxygen, and the blood goes from perfectly oxygenated to deoxygenated. And we found that our measurements of tissue oxygen saturation very well match this Hill dissociation curve. We can vary the flow into or out of tissue compartments. That very first picture I showed you during surgery where we blocked blood flow in the pig flap, this is how we did it. We have an occlusion balloon that can step down an accurate flow probe that's invasive, so we can step down blood flow into the flap, and we can then observe changes in tissue oxygenation and demonstrate sensitivity of our measurements to these real physiological changes in a controlled environment. We can look at the effects of hemorrhage, so blood loss. This is a collaboration with the military where we're looking at correlating our measurements versus measurements of mean arterial pressure in 4 pigs and showing a fairly good correlation. The idea is that you might have an early warning sign for shock by being able to monitor hemoglobin non-invasively in a non-contact way. You can also assess burn damage. So when you burn tissue, it turns out that the burn is just kind of changing phase and the collagen is melting. And that's causing a scattering contrast signal that has been otherwise very difficult to resolve, except with SFDI, where we can really isolate scattering. And based on a publication last year, Aman Mazar at Modulated Imaging in collaboration with Vanderbilt, we were able to show with histological validation that an index that we created with the MI or the SFDI signals that was primarily based on tissue scattering linearly correlated to the histologically calculated depth of the burn. More recently, we've focused a lot on improving the stability of the oxygen and hemoglobin signals in the presence of varying melanin. Skin is a very complex model, and it turned out to be the one problem we were working on that really you could not trust a homogeneous assumption in depth. And so we've modeled that with the computational techniques that you're learning about this week, with truly the tools that are coming from the Virtual Photonics technology program, being able to vary with complex layered models, including melanin versus wavelength and spatial frequency. And we've been able to calculate now the scattering cross-section, melanin coefficient, total hemoglobin, and tissue oxygen saturation. And we've done various validation experiments to show that when we do an arm cuff occlusion, for example, the tissue oxygen saturation changes that we calculate. So you see it'll decrease, go dark, and then when we release the cuff, it hyper saturates, and then it goes back to normal. And meanwhile, the melanin and this tissue scattering are not changing, which was by design. That was our goal, is to make sure that those values do not have crosstalk. And there's various ways to look at crosstalk, and I have those here. Interesting medical application at the Beckman Laser Institute that is useful for skin is to be able to do individualized patient care. So the ability to take a picture of a wound or a surgical planning site. In this case, this patient has a port wine stain. They're going to be illuminated with laser light to blow up the blood vessels. And if we can, on an individual patient basis, say, this is the melanin, this is the superficial blood, this is the deeper blood, we could tune laser parameters and allow a most optimized therapy. And ongoing work is also interesting to be able to validate optical properties at the mesoscale and the microscale. So SFDI-derived parameters versus parameters that you can get from a multiphoton microscope, for example. This is a clinical multiphoton microscope. It's quite a unique tool. Karsten Koenig developed it, and there's one in the Advanced Technology Suite at the Beckman Laser Institute, and it allows you to visualize elastin and collagen and melanin all spatially resolved in depth, and allows you to do studies of advanced tissue skin modeling and understand for various populations what are the differences in thickness, densities, where are the melanin where is the melanin localized, and what are the average shapes and sizes of melanin absorbers and collagen absorbers, collagen fibrils. So thank you very much to all of the collaborators at BLI that have allowed this work to occur, especially to Fred Bevilacqua, who, as Vasan said, was kind of the nucleus of SFDI, and I was honored to be able to carry the torch and do the validation of the technique. And of course to Bruce Tromberg and Tony Durkin, who were my advisors during grad school. Thanks also to the funding mechanisms at NIH that allow companies to get money, just like an academic professor would. These are SBIR, Small Business Innovative Research. We've raised about $7 million at the company to continue to do research and validate the technology and build the devices you've seen today. Thanks to the Virtual Photonics Project for letting me participate, and also for all of the tools that we use and rely on today to do computation at Modulated Imaging. And thanks to the Modulated Imaging Inc. team. This is us shipping one of our devices to a corporate customer this year. We were all very excited to do that. So here's my contact information. Thank you to Sylvain Zhu for sharing some of his slides today. Thanks for your time.
Questions for David? I think
All right.
to stretch.
I stunned them. Oh, we have a question from Tom O'Sullivan in the peanut gallery.
What's the smallest resolution that you regularly resolve in terms of optical properties?
Yeah, what's the smallest resolution you can resolve optical properties? The answer is it depends on the optical property. So absorption, because of its longer interaction lengths, and typically when absorption is low, the resolution is lower. If you do a line, if you image a phantom that has a step function in optical properties, what you'll see is absorption has a sigmoidal shape that's very kind of distributed. There's a lot of diffusion back and forth between the two compartments. If you look at scattering for that same sample, it's sharper. So, same centered optical properties. Scattering just has shorter interaction lengths. I bet if we could, resolve anisotropy and scattering cross sections separate from each other, there would be yet another spatial scale at which we could do things, compare, contrast, and then with depth is the other issue. So the step function, if you're observing right at the surface, is going to have the highest resolution, and as you add a homogeneous layer above that step function and optical properties, that sigmoid will blur out and become more elongated. So I always say about a millimeter is the resolution, but scattering is sharper than that, absorption is less than that for turbid tissues in the near infrared. For the visible, hundreds of microns for sure. Ability to resolve absorption and scattering when absorption and scattering are on similar length scales is difficult. So that's the challenge there.
Yeah, it's an interesting philosophical question because what is, over a millimeter, your chances of having an absorption event in tissues, right, is very small, right? Because that photon path length is tens of centimeters, probably, 10 centimeters, for example.
Yeah.
So just philosophically, what does it mean to have an optical property in this small region? Because it's totally dependent on what's around it.
It's totally dependent. And that's why, absorption versus scattering has a different shape because, we talk about banana functions in spatially resolved spectroscopy. I usually talk about photon cantaloupes in SFDI, because you're looking at a pixel, but you're looking at photons that are coming from a volume beneath that pixel. You're illuminating everywhere, but you're detecting this, mango or cantaloupe or I don't know, kiwi. Kiwi is a good one. So yes, you're absolutely right. It's a philosophical question.
When you were going over the history of SFDI, you mentioned that in one of the citations they looked at radially spatial frequency changing, like radially they would change the spatial frequency?
Yes.
Or maybe I misheard you.
Yes.
Is that
Yeah, they're concentric circles, binary circles.
Yeah. So I guess what is the advantage or disadvantage of that versus what you guys do, which is just planar?
Good question. What is the advantage of these radial signals versus planar? Well, one of the things that we realized was that for most things, the direction of the sine wave didn't really matter because optical properties are roughly scalar kinds of parameters. Modulo things where scattering might be varying much more on one axis versus another. Tyler Rice and Soren Konecki worked on something like that. But otherwise, no matter which way you look at an absorber, it's going to absorb. So we've typically only needed one dimension to make these measurements, and it has just been simpler to illuminate along one axis as opposed to phase shift along a central axis. But they took a Fourier transform of those circles, so they were able to look at the MTF in computational space. From a measurement perspective, shining sine waves is useful for SFDI, but if you think about sine waves in 2 dimensions, it's not a sine wave anymore. If you were to do a sine wave in 2 dimensions and shift phases, what you'd see is you have a point right in the middle. You have a very sharply changing feature right in the center of your image. 2-dimensional sine wave is a Bessel function. So in order to do SFDI in 2D, truly 2D, you would illuminate with Bessel functions, basically, and look at the amplitude of the Bessel function.
And would there be any difference in the profiling, the height and angle profiling between the two?
It could be. It might be very geometry dependent. It might be that for spherical kind of samples that it could be advantageous to have a radially symmetric pattern instead of one that was varying just along one axis. Yeah, absolutely.
Okay, thanks.
Yeah. Question?
You mentioned a little bit about when you look at the brain, looking at the neurons, and you mentioned that you could distinguish between hyperpolarization and depolarization. I was wondering how'd you do that? Or
well, so I can't even show you the data. I apologize. But in the brain, looking at depolarization, this is a very slow wave. When I say depolarization, I mean this broad cortical spreading depression wave, which the cells try to keep up and hyperpolarize the membrane, but at some point it gives up and they depolarize. And so you see this propagation of this diffuse depolarization wave that occurs millimeters per minute, so it's very slow. There's also a fast signal, which is the actual time, they call it the fast signal, the depolarization of a neuron, and I'm not measuring that. But our hypothesis was that the changes in analytes from one side of the cell compartment to the other change a localized index of refraction, which on a macroscopic or mesoscopic scale results in a change in the average scattering cross-section. But we never took that a next step to validate that. So that's just the hypothesis.
was this looking at a neuron? And when you said the end of the term, you're looking at like axon?
No, we were looking at an entire brain.
Oh,
so
entire brain.
every pixel represented hundreds or thousands of neurons.
Right.
And we're looking at the bulk change in the observed optical scattering as a result of the individual neurons depolarizing due to spreading depression.
Okay. Let's see.
Yes, sir.
You got me thinking a little bit when you were talking about the finger imprint and the circulation return, perfusion return to the area for a diabetic.
Mm-hmm.
And then I was looking at how you have a little water band down at 970.
Mm-hmm.
And diabetics tend to, in the lower extremities where they have these ulcers and everything, have to retain a lot of water. And I was wondering if you'd thought about the idea of trying to get the proper shallow depth measurement of water in combined with your hemoglobin return measurement.
Yeah, absolutely. So diabetes and water. We've actually, I think there's a lot of potential for water in many different fields, and diabetic cases in burn injuries. So people are doing burn assessment, and when they do resuscitation by giving fluids, they have to be very accurate about the hydration of the individual and the hydration of the wound. If they get it too high or too low and they give too much or too little water, it can be catastrophic for the patient. There's a lot of different areas we think water it would be very interesting to look at, and we haven't pursued it. We haven't shown anything publicly about that as a company, but we've definitely talked about it for a long time.
We've seen that it's going to be a different set of information, being that with a diabetic it would be the absence of hemoglobin return, but when you have retained water, I think the recovery of that spot might be at a different rate.
Yeah, thank you for your comment.
I just had a quick question. I know you said that it's beneficial to use like a bezel function for 2D. I was wondering if you looked into anything else like square lattices or hexagonal lattice to kind of split up the light so you have multiple points.
Yeah, you certainly can use various structured light in order to generate the contrast that you want. Kyle Nadeau talked a little bit about that in his dissertation defense. If you illuminate with a square wave, that's a superposition of a bunch of frequencies all in phase, and so you can use computational approaches to decouple those, where you would do narrow band filtering of each different frequency and then combine them together, and that's something he did. You can use one projection in one direction and a projection in the other direction, and if you can decouple those, you can do the profilometry and the SFD at the same time. There's a lot of different mixing and matching you can do.
Did you say it's not very beneficial unless you're doing 2D?
What I'd say is most of those approaches, when I think about them, I immediately think about the trade-offs I'm making in dynamic range and separability of signals. So in the presence of motion in room light and finite imaging space and curvature of surfaces, when I'm dedicating, the dynamic range of my camera, half of it is background light, then the rest is, right now it's one frequency, but if I have to do multiple frequencies in that same dynamic range, then I need mathematical approaches to accurately separate them, which has its limitations, especially in finite space when you try to do Fourier filtering, and then also just sharing dynamic range between them reduces the SNR for each signal.
Yeah, thank you.
No, thanks for your question.
Just to continue along the same lines, if you do it in a simple kind of square wave and then you see all the Fourier moments of that, the thing that's interesting there is that the largest dynamic range you have is at the lowest spatial frequency, where the reflectance is likely to have the most dynamic range. And actually, at the higher spatial frequency, your maximum signal is smaller, and then in reality, the reflectance signals at those higher spatial frequencies are intrinsically smaller. So you're getting squeezed in two ways simultaneously.
That's exactly right.
So that's really hurting your dynamic range at high frequencies.
It's already hard. Why make it harder? It's usually the way I end up thinking about it. But there are definitely reasons to go faster that compel you to do more with fewer patterns, for sure. But yeah, tissue's a low-pass filter. Those SFD high-frequency signals that you need to separate absorption and scattering are also the noisiest ones because it's sitting on a large DC background. It's also a bigger problem in transmission mode. If you try to transmit a spatial frequency domain through a thick slab of tissue, what you'll see is that there's a strong DC background, and if you're good enough, you can see a small oscillation on the background, but it might be 10 to the minus 6 if it's thick enough. So.